The next part of this is part of these programs that we always like to do because it really mixes it up and allows a number of our speakers to jump in on issues that are important for us. That's a series of cases. So leading this discussion will be Eric Daar. Eric is professor of medicine at UCLA. I'll try to do this without looking at my notes. I'll probably just forget everything that I was going to say. Eric has been, again, a stalwart leader in HIV for decades, fair to say, at Harbor General, which is one of the strong UCLA affiliates just to the south of the main campus. It's not Harbor View, that's up in Seattle. But Eric has been doing this for a long time, and Eric will take us through a series of cases that will test the audience and test our speakers. So take it away, Eric.
Thanks.
You can come up. I'll slide it.
Thanks, Paul, and thanks all of you for being here, and for my victims, my colleagues who are willing to put themselves on the line and help us walk through some of these cases along with all of you. And this is an opportunity really to hopefully integrate some of what you've heard this morning and a little bit more what you'll hear this afternoon into actual clinical practice. And I see this from the perspective, as Paul said, I work at Harbor UCLA, and I do get introduced often as being from Harbor View, so you're right, people get confused. It's a safety net hospital in Los Angeles County. We take care of a large number of people who have very complicated lives and multiple diagnoses and deal with a lot of the challenges that I know that all of you do in your clinical practice. And then thinking through the kinds of cases I wanted to present, I was really trying to focus on what we really do the most of. And we'll talk a little bit about getting people started on therapy and then thinking about modifying therapy in clinical practice. And then we'll talk about switching, which is one of the more common things I do nowadays, is take people who are on a stable regimen and switch them for any one of a number of reasons, and focus on some of the key principles and the data that's informed our strategies in addressing these unique cases. So let me go ahead and get started. These are my relationships, learning objectives that we'll go through, and again, talking about starting and switching, as well as switching in people who have underlying resistance, and then talk a little bit more in integrating some of the things we've learned this morning about novel strategies for addressing those people who have difficulty adhering with oral therapy, and then learn more about how the audience is addressing that and perhaps the panel in the real world. So we'll start with this first-line therapy and then switch. So it's a 42-year-old man with some comorbid conditions, including hypertension, dyslipidemia, recently presented with thrush, found to have HIV with a viral load of over 1 million, a CD4 of 24. His examination in laboratories are remarkable for him being obese with a BMI of 37. Blood pressure and lipids are well controlled on an ACE inhibitor and a statin. He has a hemoglobin A1C of 6.4, creatinine clearance of 45 mils per minute. He had a genotype done, again, he's treatment naive, and he showed a K103N, suggesting transmitted resistance. And then he had some hepatitis serologies, and his Hep B surface antigen is negative, but surface antibody and core antibody are positive. Hep C antibody is negative. And he'd like a simple regimen, but he's willing to start whatever you recommend. And I'll start you all off by voting on which would be your preferred option if he was open to whatever suggestions you had. Dolutegravir with nukes, bictegravir TAF FTC, darunavir cobicistat plus nukes, dolutegravir plus 3TC, or something else. So again, newly diagnosed, high viral load, low CD4, multiple comorbid conditions, starting therapy for the first time. Go ahead and vote. Okay. Still getting some responses. Thank you all. Okay, let's go ahead. So 90% bictegravir, TAF, FTC. Anyone on the panel that would have preferred or recommended something different? Okay. Okay, great. Very good. Now, what if, oh, Steve?
I would just comment about the other choices. I'd be reluctant for the dolutegravir 3TC with a viral load of 1.2 million, and if there's something else had been a real pivirine like that switch, dolutegravir pivirine, I would have been uncomfortable with that as well. So I think there are answers that I would be less comfortable with, but I agree with the audience. And
So, but what if the scenario was a little different and his CD4s were 390 and his viral load were 86,000? Go ahead and vote. Same comorbid conditions, same treatment naive, same K103N. Still getting some more votes. Okay, let's go ahead. Wow, that changed everything, didn't it? No. We did have some dolutegravir 3TC takers, and this is obviously what I had in mind in this particular case, because it's not an unusual scenario to have somebody who's coming in with multiple comorbid conditions, and it does stress a little bit our first-line regimens, although our first-line regimens are still awful good. Anyone on the panel switch their vote to dolutegravir 3TC? Connie, did you?
Well, I didn't vote, but
In your mind.
in my mind, this is somebody I would consider using dolutegravir in 3TC, first of all, because he has a high BMI, and I'd be a little bit concerned about the TAF contribution to weight gain with bictegravir, and then his creatinine clearance is fairly low, so I might want to avoid, at least initially, the tenofovir or TAF, although tenofovir itself is more important. But so anyway, those are the reasons I would consider using that.
Anyone on the panel? I mean, can somebody weigh in on what is the role for dolutegravir 3TC if you're not going to use it in this patient? I'm not saying there should be. I'm just curious, is there any situation where you could imagine dolutegravir 3TC bumping up above bictegravir TAF FTC, unless maybe they had even more severe renal disease?
Yeah, probably that would be it. I agree with Connie, and I think that Darcy mentioned earlier in the context of weight and switching, in that case, switching from bictegravir FTC TAF to dolutegravir TTC had not been associated with any change in weight. That does not mean necessarily that starting dolutegravir TTC would not just with less weight gain, but we don't know. and that's, so I don't think that I would pick it. I mean, I don't know if that would be a consideration. It makes sense since INSTIS and TAF together in the advanced trial had more weight gain than INSTI alone, but maybe they also have more weight gain than TAF alone. I don't know. So it's really.
Okay, well, we have a long way to go, so I won't belabor this point anymore, but the guidelines do recommend a variety of standard 3-drug regimens, but both of the prominent US guidelines do have dolutegravir 3TC as one of the recommended options for most people with HIV, with the caveat in the guidelines, at least, that we don't recommend it in people who have viral loads of over 500,000 because that group was not formally included in the registrational trials, although the FDA decided when they approved these drugs, this regimen, to exclude that as a concern and saying that it's an option for everybody. And here's just some of the original 96-week data from the 2 Gemini trials, and I think clearly it was as effective as a 3-drug regimen in treatment-naive people, most of whom had viral loads of less than 500,000, some who at baseline actually exceeded 500,000. And importantly, there was no resistance selected for in any of the arms. So I think it is a viable option. It's still not, when people ask me, who do you use it in, I have the same problem as everybody else. I think it's really at what point are you sufficiently concerned about TAF to jump to this as another option. The other area that I always worry a little bit about is the person who I'm concerned about adherence. Because obviously registrational trials are select, usually highly adherent patient populations. So we don't have quite the stress test for this, but we're also not seeing a ton of reports in the literature of people failing this with resistance in clinical practice. Okay, let's move on. So he got started on Big TAF FTC, like everybody here recommended, tolerated it well, took it appropriately, achieved undetectable viral loads, remained suppressed for a year. CD4 cows now had a robust increase to about 500. And he comes in saying that he'd heard about long-acting therapy and he's interested in your thoughts about whether he would be a good candidate or not. Which of these best reflects what you would tell him? You're not a good candidate because you had an NNRTI resistant mutation. Remember, he has K103N, and I summarize in the box below. You're not a good candidate because of your elevated BMI. You're not a good candidate because you are HBV exposed. He's surface antibody and core antibody positive, antigen negative. You're not a good candidate for multiple reasons. You're a good candidate for long-acting cabrylpiferine if you want it. So go ahead and vote. Okay, so about half, a little less than half, if I wait longer, it'll be half, are a good candidate for long-acting cabrylpiferine. There were some concerns about the NNRTI resistance, maybe multiple other reasons. You know, Darcy, where are you on this?
Yeah, so I have to agree with the audience. With the one caveat, what I teach my fellows, which Dr. Daar taught me when I was a fellow, is that whenever you're thinking about switching a patient who's doing well on their current therapy, you want to make sure there's a really good reason and compelling reason to switch, because if they're doing well, why rock the boat? So if this patient really wanted to get off of, daily oral medication and was interested in injectable therapy, I think all of the other factors that we've learned about the patient, he's a good candidate. The K103N is not going to confer resistance to rilpivirine, and it's important to remember he had transmitted drug resistance, not acquired drug resistance. I think that's one thing that gets tricky. When I see a K103N in a patient who had virologic failure in the past, I get nervous. Could there be other NNRTI resistance that will confer resistance to rilpivirine or reduce susceptibility that maybe we're not seeing in genotypic testing? But this is transmitted resistance, so I feel reassured the patient's done well and remains suppressed on their current regimen. And then we talked about the BMI consideration as well, which is less of an issue, again, if there's a compelling reason to switch the patient.
Okay, good. Oh yeah, Judy, I'm sorry.
No, I just wanted to throw a kind of a wrench in this a little bit, and that's the question about HBV exposed, and this comes up a lot, but we did a small case series of 4 patients, and all who had acute Hep B after a switch. And one in particular was a woman who was isolated core only, but then was vaccinated, as Steve recommended. But her response to vaccine was above 10, but not above 100. So on paper, she would look like somebody, right, with the serologies coming to you, core positive, antibody positive, but she on the switch developed acute Hep B. So I think it's important. What we actually now have a best practice alert to do Hep serologies. But on the people that are core and antibody positive, we actually ask them if they've been vaccinated and try to find out if, in fact, they did have isolated core. So it might make a difference.
Yeah, no, and we're going to get to that more in a moment, actually. So that's a great lead-in. But it does, while, Darcy agreed with the audience, I don't know if anyone on the panel disagreed other than that caveat right now with the, because there are a lot of things here that have been shown in some settings to be a problem.
Yeah, and Darcy mentioned all of those in her discussion, and each one of them alone probably wouldn't argue against using it, but the confluence of all of them together, and those are the BMI, the hepatitis issue that Judy just mentioned, and the renal dysfunction, which I have a little bit of problem with. Rilpivirine hasn't really been studied in people with creatinine clearances that low. So I'd be a little bit hesitant to use it for that reason. So I think it's not so much any single one factor, but there may be multiple factors that contribute to him maybe not being the best candidate for that.
Yeah. Steve?
Yeah, in our use of this drug, this person is asking your advice, which is fine. But, some people find the injectable ART liberating, stigma reducing, everything, and so on. I think it's important to kind of explore that with the patients, because sometimes we'll say, well, you're on a statin drug, antihypertensives, you're taking medications every day, and so on. Does it really make sense to do this? But for some people, it's really kind of a dramatic.
Yeah, and that really gets to Darcy, thanks for attributing me, but there should be a good reason to do it. And the good reason in this case would be if it means something to the patient, right? Because otherwise, they're doing great, and they'll continue to do great. The other point that you made, Darcy, which I think is an important one, is the transmitted resistance. And you hedged a little bit during your presentation. You said how, no resistance to the rilpivirine. And you said, usually they say without a history of virologic failure, because that's what the package insert says. No viral, but you can have K103N. So it's basically implying that you know that it's transmitted resistance and not selected for. And then you hedged a little bit by saying that, well, but maybe in some settings, a history of virologic failure is okay. And I think that's, you have to individualize. I completely agree. Okay, let's move on. We've got a lot to cover. So the comorbidity issue came up. Both Judy and Connie brought up this Hep B issue. So the question for all of you is, should we be concerned about it in this person's core antibody positive, surface antibody positive? Are we concerned about the risk of removing a Hep B active drug? Definitely yes, definitely no, possibly yes. I don't understand what you're talking about, or other. I have to admit, the first time this came up, meant some time ago, my initial reaction was, I don't understand what you're talking about. So that's why I added that. So go ahead and vote. Okay, great. Possibly yes.
That's my fault, I'm sorry. I'm getting interrogated here too with this bright light. So I can't even look at the audience.
So, I think that that is legitimate. We'll come back to reviewing some of the data and sort of where we're at with this. But before we do, let me just ask the panel. Would you feel differently if it was core antibody, surface antibody negative as far as what the next step would be? Steve?
Well, again, I think, the guidelines would want you to try to make a differentiation of what the cause of the isolated core antibody is. So, I think you would vaccinate and see if there's a response. I'm kind of troubled by Judy's case because a lot of folks we have with that pattern, get switched and we don't really think about it.
I know, I think it is. There's a lot of controversy going right now in the liver disease guidelines about this. And some hepatologists now are not recommending to vaccinate people that are core only because of that concern that they are higher risk of reactivation should they go on immunosuppressant therapies, right? And that's really the key issue, I think. And the other that you can do, which is what, typically we do, is, again, you have that discussion that there could be a risk of reactivation. And again, not in the guidelines, but we monitor then for DNA in those individuals to see if they do flare, because it's usually soon after that they flare. And it may be something unique about that you have people on a tenofovir-containing regimen and it's taking it away versus starting somebody.
And you're right, because that was my, I don't know what you're talking about thing is.
Right.
This person, if you were going to start him on therapy, you would think nothing about not giving a Hep B active drug. Because he doesn't have chronic Hep B.
Right.
But the circumstances may be different. Darcy?
I was just going to add, we have about 250 patients on cabrolpivrin in our clinic, and we've had 7 patients who are isolated core antibody positive go on to develop transaminitis and HBV DNA viremia after switching. And we've sort of, through shared decision-making, taken different approaches, most of the patients we put back on their oral regimen. One patient elected to stay on his injectable therapy, and we just monitor very closely, knowing that it's a risk and that the patient understands that, and has actually stayed relatively stable, and the LFTs resolved. So I think this is definitely a gray area that comes up, but I am much more concerned about this scenario than the scenario where the patient has surface antibody positivity, but still there has been at least one case described in terms of reactivation. So it's definitely something to think about, and think about monitoring after the switch, even though there's not clear guidance on that. I think it makes sense.
I also think that case I described is unique in the sense that it was vaccine, response.
Right.
Not natural immunity. So somebody that's surface antibody positive core, and unless they really go on immunosuppressants, which has been described in, the cancer literature, rheumatology, et cetera. But that I'm less concerned about. This does make me nervous about taking people off of a tenofovir regimen.
Yeah, and I think that there's enough anxiety that's now been generated. It used to not be a big issue when we were talking about going to dolutegravir 3-TC because there just wasn't as compelling a reason to do it. Now, for some patients, as Steve alluded to, there is a compelling reason to switch
Can
to
I make you
long-acting
more
therapy.
nervous? One of our patients required a liver transplant. So.
I mean, that's the thing. This isn't a bump in ALT for everybody, yeah. So, these are the kinds of anecdotes that people are referring to, but it also speaks a little bit to the limitations of the existing data. So in addition to the fact that neither the OI or treatment guidelines, at least DHHS, have really formally addressed this, we don't have a lot of data to rely on. So here are just 2 cases of people who had Hep B rebound after a switch away from Hep B active drugs. And then we had at CROI, there was a report looking at some observational data, 7 anti-core isolated versus core surface antibody positive in 34 who switched. The good news is they had no reactivations, it's small numbers in those who were surface antibody and core antibody positive, but there was 1 out of 7 who had this, you can't see this, but the y-axis for the ALT is thousands. So had a pretty significant rebound. They did respond when they got put back on Hep B active therapy. So again, the kind of limited data, and this was a series that was presented at ID Week, whereas a larger group of individuals, and I'll just have you can see over time people switched for a variety of different reasons. More recently, it's been to go on long-acting therapy where they switched off their Hep B active drug. And focus on sort of the primary endpoint of reactivation, which was identified mostly by transaminase bump followed by DNA testing, not regular routine DNA testing. And we're talking about a rare event amongst those who are surface antibody and core, but a % or so of people who are isolated core antibody. So it's not trivial. I think we would all agree, as you're doing, Judy, that we should have routine screening for hepatitis B in all of our patients, and follow the guidelines that Steve already mentioned for those who are not surface antibody positive, and immunize them prior to starting them on a non-Hep B active regimen. Do we know for sure that will reduce or prevent reactivation? Of course not, but it's probably a good practice and hopefully does reduce the risk.
I think that part about having that titer greater than 100 is what's important, because we all hear greater than 10 is that you're immune. So I think that's the difference. Right after vaccine, you really should have a robust response.
Yeah.
And so 2 of those 4 cases I mentioned, their titers were like 41 and 86. So I think that's another key issue.
Right, and I think Steve talked about the Heplisav study for non-responders that was presented at CROI as well, showing incredibly high response rates, over 90%. So we can get people to be surface antibody and core antibody positive, hopefully reduce the risk and allow them the opportunity to be on a regimen that they'd prefer to be on. So wait for more. The OI guidelines are dealing with it, Judy. The ART guidelines are also dealing with it. And the next updated version will have some more specific recommendations to address this, but imperfect because of the lack of perfect data. Okay, so the person agrees to start long-acting capryl-pivirine, says he's comfortable with every 4 or every 8-week dosing. Which of the below best reflects what you would tell him? You're willing to do Q4. If you're willing to do Q4, you should do it. If you don't have a preference, then should go with Q8 for convenience. I'm completely neutral, do whatever you want. Or I'm completely neutral, so we'll need to flip a coin. Go ahead and vote. Half said go with 8 weeks, and then a split. Anyone on the panel want to speak up? Steve?
Well, I think the vast majority of people that we currently have are on every 8 weeks, and that's still coming into the clinic 6 times a year, which is more than many of our patients come in. So I think we might have like one person on Q4 weeks. So I think 8 weeks, it's the advantage of intermittent therapy, and most patients are choosing that.
Roger, any reservations about?
No, I'm just saying that in the trials, numerically, there were more failures in the Q8 weeks. That wasn't statistically significant, but just a word of caution.
Darcy Judy and then Darcy?
I was just going to say, most of the time we start with the Q4 weeks just for tolerability and have the person come back and see how they're doing and go to 8 weeks. The other scenario I see is that the people on 8 weeks can't take the volume, especially if they're thinner. And, or especially too, if they're couch potatoes, because you really need to walk this off. So if you got somebody that just is going home and sitting down, they do better on 4 weeks. At least in our experience from the clinical trials we did.
Sounds like a role for shared decision-making.
Yes,
Darcy?
very much.
I was just going to add, so in our clinic, the bottleneck for getting started on capryl-pivirine is administration and nursing staffing, because we just don't have the resources to get people going. So even though it doesn't necessarily apply to this individual patient, from a resources perspective, the Q8 week is what we're doing mostly, unless there's very specific situations, because really the bottleneck is we don't have enough staff for administration.
Okay, so he starts long-acting cab without the oral lead-in, which, as you all know, is optional, placed on every 8 week with the 2-inch needle, as Darcy recommended, because of his BMI, receives the first dose, then repeat dose on a month later, and then returns 8 weeks later with a viral load of 120, which was repeated about 10 days later and was 150. What would you recommend? Repeat the viral load and a genotype in another few weeks, switch to Q4, switch back to their 3-drug regimen, oral regimen, switch to a boosted PI-based regimen, or something else? Go ahead and vote. These are real-world cases that keep me up at night. So about half repeat viral load and a genotype, assuming you can get it, depending on what the follow-up viral load is, and a few of others. Darcy, 250, you must have seen a few of these.
Yeah, so I would say the more common scenario that I've seen is patients who had low-level viremia on their oral therapy switch over to cabergoline for a variety of different reasons, and then continue to have low-level viremia. So that doesn't necessarily address that issue or change that. I think the question that you worry about here is, right, is this just low-level viremia, just in quotation marks, or is this beginning of virologic failure, with resistance? And so in these cases, I go back, take a very deep dive of, could I have missed, baseline resistance or other things that could put the patient at risk for virologic failure? And if I don't find any of those, which I don't think this patient has, then I think about, are they getting therapeutic drug levels? And could that be because of the Q8-week dosing? Could that be because of BMI? I don't know that there's necessarily data to guide switching back to Q4 weeks, but that's something that could be considered if the patient is sort of able and willing to. And then also talking to the patient about switching back to the BF-TAF. Again, if there's a really compelling reason for why they wanted to be on injectable therapy, then that decision might end up going a different direction compared to if it's not particularly compelling. So I think it's a little bit of a gray area, but definitely, yeah, lose sleep over it.
Any of the other panel members know the right answer?
Darcy just told us.
Take a deep breath.
Well, we seem to have a lot of noise in our viral load lab, and we're constantly talking to people about these viral loads that are under 200 and are measurable, so, and in people on oral therapy. So I agree with the audience. I would just stick with it and keep monitoring.
And that's what we ended up doing in this particular case, and the next time his viral load was undetectable, and it's stayed that way now for at least some period, several months at least. But it is challenging. What do we know about blips? Well, there was some new data at CROI that was presented, looking at some of the data from the registrational trials. They defined blips in those cases as a single RNA of 50 to 200, followed by an undetectable, sort of the standard definition we've always used for blips, so different than this particular patient. And the key thing that they found was that there were some confirmed virologic failures, but it was no different between the two arms. That was in the controlled trials with the oral regimen versus long-acting. And they found there was no relationship between blipping and failure. The failures were not the blippers. So again, it's a little different. I asked the presenter at this conference, did they have any that had, blip level RNAs consecutively? And they said there were just a couple. And those people didn't fail, but the numbers were tiny. So I think these are things that we're going to have to encounter, and we're going to have to deal with our patients. And
We keep learning this blip lesson over and over.
Yep.
Every time there's a new regimen.
Yep. Just new scenarios, new anxieties, yes. And we already talked about some of the risk factors for virologic failure, so I won't go over that again. And I'm going to go ahead and move on to the next case. And I warned the panel not to panic if the first case takes too long. The next ones are much shorter. So this is switching in somebody who has underlying resistance. So this isn't the patient who's always been suppressed on their oral regimen who's thinking about a switch. 32-year-old woman presents 6 years ago with thrush, a CD4 count of 40, started back then in an outside clinic on efavirenz TDF-FTC. Viral load went to undetectable for about a year, then experienced a variety of social challenges with housing insecurity, substance use, bounced between providers while on and off therapy with viremia before finally just stopping therapy. Her social situation has now stabilized, and 2 years ago had a very low CD4, a wild-type virus, but off antiretrovirals, and was started by an outside provider on darunavir, ritonavir, dolutegravir, and ZDV3TC. And she was told the reason they created this regimen was because there was concern that this person had selected for a lot of nuke and potentially non-nuke resistance when they were flailing on the efavirenz TDF-FTC. In any event, the patient did well on the regimen. The viral load went up, but was concerned about weight gain, concerned about the number of pills, otherwise reportedly tolerating the AZT and 3TC pretty well, but had, some chronic abdominal distension and loose stools. And this was not a great regimen for her. It's understandable why it was started in the absence of data, but not one that was working well for her. So the first question is, she again comes in, had been off therapy for a while, now on suppressive therapy, and is looking to try to get to something easier to take. Would you do an archive resistance test? Yes, no, or you're not sure?
Yeah, it's so bad.
Okay. So 2/3 yes. I'm hearing some murmuring from the panel. Anybody want to share it?
Connie and I were just saying we thought it should be banned.
I will say this, since I'm from Los Angeles, and can say this, that a good analogy is the archive resistance test to Los Angeles. It's a city that everybody loves to hate. And similarly, the archive resistance test is the test that everybody loves to hate. I think the thing to remember about it is that it's specific but not sensitive. So it might miss mutations. So if you see something that maybe you're expecting to see based on the treatment history and you don't see it, you can't be reassured that it's not there. If you see a mutation that's there, then it probably is there. But it's hard to know, does that predict lack of viral activity or not? And it's a big question mark, and it's expensive.
I completely agree with Darcy. Another concern here is before you do any test, you need to decide what to do with the results. What if you find an M184V? What if you find a K65R? Is there any evidence that that would impact the choice of your future treatment? I'm not so sure.
Steve?
Yeah, I think this is a test that we've all thought is so cool. I kind of really wanted it to work, but I think the sensitivity issue is particularly a problem. If you have a history of plasma genotypes, there's all sorts of mutations that are missed. So I'm not really sure it changes therapy. I can point to a few anecdotes where like we had unexpected rilpivirine resistance and we didn't use CAB-LA. So there are occasional cases, but it's an expensive test, and I'm not sure it affects management very often.
Now,
The time you would get this is just what you said. And watching it work. That might be useful in the situation where you don't have a genotype you believe in.
but the sensitivity issue is real, and then the specificity issue, Darcy didn't really go into it from the CARE study. She mentioned, though, that remember 10, 15% of those people had archived resistance. Now, the devil is in the details. We don't know what those resistant mutations were. But despite 10+% of people having resistance to rilpivirine or integrase, everybody stayed suppressed on long-acting. So it raises the issue until we have more data as to both the specificity as well as the sensitivity. But if you order it, you just need to know to interpret it with caution. That's the main thing. So an archived genotype was not sent. What would you recommend now? So again, remember, complicated history, potentially a lot of resistance on efavirenz, TDF-FTC, virologically doing well on a very complicated regimen, darunavir, ritonavir, dolutegravir, ZDV3TC, but desperately needs something different to manage some of the side effects and convenience. So would you say, no, we're going to leave the person, we may change the nukes, but we're going to leave the person on the boosted PI and dolutegravir. We're going to go to dolutegravir with nukes, TAF-FTC, dolutegravir with ZDV3TC, bictegravir TAF-FTC, boosted PI and nukes, long-acting CAB rilpivirine, patient is suppressed, something else. Go ahead and vote. Oops. You guys are really hanging in there this morning. Thank you. Okay, so a lot of people BF test 60%. This is maybe as close to a majority since first-line therapy question. Anyone on the panel want to weigh in as to what you would do?
It would be nice to get her off the boosted PI since it sounds like she's having some GI symptoms. And the question is, what would you switch to? And assuming that the NRTIs are not going to be particularly active. So I think that's sort of what you're aiming for. You could very easily consolidate her current regimen to pretty much an equivalent with 2 drugs once a day, right, with boosted darunavir, FTC TAF, plus dolutegravir. The question is, do you need all of that? And I think probably not with second-gen INSTIs, even if you do have underlying NRTI resistance based on Nadia and some other, I think I always say it backwards, a 2DS or 2SD study in terms of patients that had a lot of NRTI resistance but still maintained suppression with second-gen, so.
Yeah, and this is, I think this has been one of the biggest changes in the way we think about treating patients, both for switch and virologic failure, is the data. And we'll talk a little bit about the specifics from those studies, because I think they're really important. The data showing that with a high barrier INSTI or boosted PI, that you probably can get away with that as the only fully active drug in a regimen. As long as there's some other partially active drugs included. And, it wasn't that long ago that, first-line failure always went down to a boosted PI because it's the only thing you could rely on if there wasn't a good backbone. Now we know that that's true for INSTIs as well. So the data, I think, supports this kind of an option for the patient. There's also data that shows that even with tenofovir resistance, the K65R mutation, which supposedly results in hypersusceptibility to AZT, which is my guess why the provider actually put this person on AZT, that even in that setting where you would expect AZT to be really effective and tenofovir not, that tenofovir is as effective and maybe even a little better, at least from a tolerability perspective. Judy?
So I agree with the audience. I mean, that's what I would do as well. But I just wanted to point out, if you look back on the trials with failure from efavirenz, you had a sequence. So you had the M184, you had the K103, and long before you had the K65R. And you're unlikely to accumulate the other, the rilpivirine resistant mutation. So your other something else could be dolutegravir plus rilpivirine.
Be very risky in somebody who's a known NRTI failure without a genotype.
Just on a triplet, though, yeah.
It takes a while, but this person floundered about for quite a while.
Yeah.
Yeah, but I think that, I guess what I believe we're getting at is that a lot of the data for managing this patient, extrapolations, a lot of this extrapolation is from failure studies in Africa. Where they use people who have failed NNRTIs and switch them. So now we're switching virologically suppressed people who have had failures evidenced by some resistance. But still, these are extrapolations.
Yeah. Connie, I think, and then Steve. You got to share your microphone, Steve.
You have to share. There also was a very nice study done in people with high-level nuke resistance showing persistent activity of 3TC in the background regimen. So there is some partial activity of FTC, even in the setting of M184V and K65R, in making that first regimen choice even more attractive.
Yeah, I like the choice of the big TAF FTC, but I do think in folks that are kind of repeatedly non-adherent, I kind of worry about, that being a more chronic issue, and I think that's sometimes why we end up using more kind of complex regimens like the boosted darunavir with an integrase inhibitor, because we're kind of feeling we need a little bit of insurance in somebody that has had adherence issues in the past.
But then that can contribute to more lack of adherence because you're giving a more complex regimen that has more side effects.
It's always,
So
right?
it's always that.
Yeah.
Yeah, but 2 pills once a day, and that's, it kind of,
So with all of that being said, my question for the panel quickly is, let's say I did do an archive genotype, and let's say it showed the 103N, K65R, and 184V, which you would say is plausible based on the patient's treatment history. Would that have changed your recommendation at all? I see a lot of no's. And I think that's really the important point. So this was really the first hint as to how much you can get away with a boosted PI, was from one of 3 really large registrational trials, or pivotal trials, I should say, looking at first-line NNRTI failures and giving them a boosted PI with nukes. And they did these post hoc analyses where they looked at how many active nukes were in the regimen, and then they broke down the response rate based on that. And I'll have you focus on the top lines. And basically, it showed that even if you had no predicted first-line nukes to be fully active, you had these response rates in the 80% range, just as good as if you had 1 or 2 of the nukes. So this was the first hint that with a boosted PI, even without fully active nukes, or not knowing the susceptibility to nukes, it's likely to be very effective. And then the Nadia trial was the one that Darcy referred to, which basically asks the question, is the same going to be true with the second-generation integrase inhibitor? Only in this case, in addition to taking these first-line NNRTI failures without known underlying resistance testing done, so I didn't say that right, but they didn't have resistance testing, so we didn't know how much resistance they did or didn't have, randomized them to the boosted PI, which we knew would work with nukes, versus the integrase, dolutegravir, which we didn't know would work with nukes if none of them were fully active, and then did a second randomization to say, well, you know, should we be giving ZDV3TC or TDF3TC? And that's what the study looked at, and I focused on just the key take-home message from my perspective at the bottom of the slide, is the number of predicted active nukes. They did not know at the time of randomization, but then they retroactively looked at the stored sample and determined that some people had no predicted fully active nukes. And basically, these are all people who had 184V and K65R, which is the signature mutation that's supposed to make tenofovir ineffective. And you can see that the response rates were equivalent and high, 90%, in those who received the integrase with partially active nukes and those who received the boosted PI. So now we really have the same kind of data that supports that if you can suppress somebody who's viremic on an INSTI with partially active nukes, there's every reason to believe you will be able to maintain suppression, which should be easier in the same kind of scenario. But all of the data to inform the decision about these particular patients was derived and extrapolated from these failure trials. Probably reasonable to do so, but it wasn't until very recently, oh, and I should mention there was a trade-off. There wasn't a free ride. For those who got the INSTI, there were some who developed INSTI resistance, 2%. Not a lot, but there were some. No PI patients developed PI resistance. So there is a trade-off, and I think that's something that one needs to discuss with their patient when they're deciding between the INSTI or the boosted PI with nukes. And then there was this study that was this switch to dolutegravir study in people who had previously failed non-nukes, got put on the boosted PI because that was the standard of care. We don't know how much underlying resistance they have, but based on other trials, we'd predict a lot of nuke resistance. And it showed a 5% viral rebound rate in suppressed people who presumably had a lot of nuke resistance. So now we have direct evidence, albeit imperfect, because we don't actually know the baseline resistance data, suggesting, again, that the 60% of you said, I'm going to go with bictegravir TAF-FTC, is probably supported by pretty good data in viral failure and in switch patients. So the patient was put on bictegravir FTC TAF, very grateful for the simplified regimen with resolution of their GI symptoms, continued viral suppression for the next year, does have issues of weight gain and wants to know if this is from the antiretrovirals and what he should do next. What would you recommend other than diet and exercise? We've talked about this, I think. Switch off the INSTI, switch off TAF, switch off both. Tell her that you don't think antiretrovirals are contributing to weight gain. Recommend a GLP-1 or something else. Go ahead and vote. Again, we talked a lot about the data. This is the patient sitting in front of you who's upset about their weight gain. Thrilled about their new regimen, but not thrilled about the weight. Oh, interesting. See, that number may or may not go up even higher later in the day. We'll see how it goes. Okay. Switch off TAF, switch off both. You know, I think it's safe to say that we probably don't know the definitive answer here, and we have to sort of drop back to, I think Darcy really, I thought, articulated it well. It's a balance between the potential benefit without any data showing that that's going to help versus the downside of leaving a first-line regimen that we know is well-tolerated, easy to take, and highly effective, pending more data.
It's another thing I would like to add, and I totally agree with Darcy as well, is that when you look at weight gain on ART, there's a huge variability. Most people don't gain. There's a small proportion gain a whole lot. And so that's important. The second thing is that a lot of the weight gain is very front-loaded. And it happens in the first year or so. So when you analyze switch data, it's important to see how soon they switched. If you look at tango, salsa, if there was a merengue trial, that would be the same result. It's that when they switch a little later, when they switch earlier, whether the difference is different, the weight trajectory, depending on how long they've been on the regimen.
And this is just an example of some of those curves. And I always look back on this after having gone down the path of, INSTIs and TAF and weight gain. And it really was based on the fact that everyone saw this enormous increase in weight, especially in the women, as having to be pathologic. I think if it weren't quite so high, people could have just as easily looked at this and said, boy, it looks like the people on the other drugs don't gain as much weight. Not a bad thing, not a good thing, a bad thing. So these have already been discussed. I think Darcy showed a reference for David Wall's recent review where they systematically summarize some of the data that exists based on switch, based on PrEP, based on trials like ADVANCE and others, and proposed what I think increasingly many of us think may be going on, in that we have certain factors that are associated with more weight gain, more return to health-like issues like high viral loads and low CD4s. And then we have certain factors that are associated with less weight gain that we would all anticipate, like OIs, substance use disorder. And then rather than certain drugs associated with an increase in weight, it's more that other drugs may be associated with mitigating the actual amount of weight gain, the quote-unquote return to health, like tenofovir and TDF and efavirenz. Again, this is just a proposed schematic of what may be going on. We still don't have all the answers. So now we're going to talk about two last short cases, I promise. One is viremic with poor adherence. So we've already heard a lot about this. This is a man, 52 years old, no past medical history, no medical problems, started on efavirenz, TDF, FTC with poor adherence and viral failure in the past with 184-103N, as you would have predicted. Despite intensive efforts over the next several years, treated with dolutegravir, bacavir 3TC, then BIC, TAF FTC, had persistent viremias and no real evidence that he was taking his medications consistently, had several genotypes sent on high viral loads that were always wild type while he was supposedly on therapy. Telltale sign that he's just not taking it. Viral load 208,000, CD4 of 50. And the patient is open to options. Which of the below do you think you would recommend? Incentivize on orals, and if able to get to less than 50 for at least 12 weeks or so, switch to long-acting caprylipivirine. Incentivize on orals to get to less than 50 for at least 4 weeks. And as soon as they're undetectable, switch to long-acting caprylipivirine. Or just switch to every 4-week or every 8-week long-acting cab, or tell him long-acting cab is too risky for him right now. Go ahead and vote. So these are real practical issues along with the data that's already been presented, talking about potential strategies for these people who have trouble adhering with oral therapy. Okay, this is kind of what I predicted, a nice distribution. Anyone on the panel want to get us started? I'm sure everybody on the panel has an opinion here.
Well, we're not able to get the drug unless we have viral
Okay.
suppression, so we're A or B.
I should have prefaced by saying, assuming you can access it, yes. Which would you do if you could, Steve, before I let you pass that off to Connie?
Well, again, I mean, I'm intrigued by the new data, but, the original kind of switch data, getting people undetectable, so I would actually try to maybe incentivize the patient to
So a latitude strategy.
a latitude strategy, take orals and kind of,
What about, how long do they have to be undetectable? So latitude changed the protocol in the middle, right? And got very loose. Yeah, got very loose. The problem is, the latitude data, I'm not going to go through it again because it's already been discussed. The latitude data that was presented at CROI was what was presented to the DSMB and nothing more. So there is a lot more we're going to learn about latitude, including, as far as I know, we don't know what proportion of people were suppressed for 4 weeks, 8 weeks, 12 weeks, or more before the switch, and whether the outcomes were any different. Anyone feel strongly about waiting longer, or can we just, as soon as we get them undetectable, switch?
Yeah, I don't feel strongly about waiting longer. I just know that the Latitude study struggled with this incentivizing on oral therapy to get undetectable. And there were actually 2 changes made during the course of the protocol because patients that incentivize on orals just did not work. And you're talking about a population that's has very big challenges to taking oral therapy, and whether you economically incentivize them or some other incentivizing, it just wasn't something that was going to get them undetectable for the 6 months that the study design originally asked for. So that was way too long, and it changed during the course of the study. So I think I would just get them undetectable and start them on
If you can.
long-acting if you can.
And
And I think the accumulating, I mean, Darcy went over it, but there's a pretty large body of accumulating data that going directly to injectable therapy in the setting of this type of patient doesn't behave any differently than if you get them undetectable on oral first.
And that's just what I was going to say. It's a little controversial, but I'm from California, so I feel like that's okay. Is that this patient has already shown they have barriers to oral therapy. So I would just go directly to injection versus, tinkering, waiting a little bit of time. We don't have money to pay patients in clinical practice to try and incentivize them as a practical issue. And then I would choose the Q4 week just for close monitoring, plus that was the administration that was done in Latitude. The one thing we haven't talked about is I'm a little anxious about an NRTI resistance with this patient. So we don't have any resistance mutations that show resistance to rilpivirine, but they did have virologic failure. They have a K103. And so, again, being controversial, maybe this is someone where I'd add some lenacapavir getting started with not a lot of data to support that.
And a key question, if you could answer it, and you may not be able to in someone like this, is when was the genotype done at the time of failing that regimen? Was it done at the time of failure and then they stopped? Or was it while they were sputtering along and potentially accumulated more than the 103N?
Yeah.
Judy, did you have a comment?
Oh, no.
Okay.
No, I was
Okay.
kind of agreeing.
Okay. So the Latitude study, I think the main points that I really wanted to add to what's already been discussed is there were some of these people who had viral loads that were detectable at the time they were switched. So in order to be randomized to step 2, you had to be undetectable, but then they had to come back and have another viral load done and randomized, and some of them were detectable, 17%. And then this issue of the duration, I think, is really an important one. My favorite anecdote from one of the patients we enrolled in this study was this was someone who was helpless as far as getting them to undetectable. We got them to undetectable. We got them to step 2. They got randomized to standard of care oral therapy. They have not been undetectable ever since.
Right.
Right? So now he comes back and we say, can we do exactly what we did last time without the money? Exactly what we did last time, only this time I promise we'll give you long-acting if you make it. It really does. Giving people a light at the end of the tunnel does make a difference and gives some people an opportunity to get there. And I guess the argument against your comment, Darcy, about the accumulating data, or Connie and Darcy, the accumulating data, it's absolutely true, but certainly it's not the quality of data that we have from a randomized control trial. So this was already discussed. The Ward 86 experience is already discussed. And then the new update in the guidelines, DHHS is also trying to sort of think through what this all means. The one question I have for the panel before we move on to one last very quick case is the IAS-USA guidelines sort of made some really important points that everything has been done to try to get them to undetectable first using orals. And then that you're looking at a group of people who are at particularly high risk for disease progression. And they use the CD4 of less than 200 or an AIDS-defining condition. Anyone on the panel feel strongly that that is the right criteria as to which population we might consider this in, or the wrong criteria? Because I know there's a lot of controversy around this particular statement. Is it too liberal to give it to everybody who has a CD4 less than 200? Or is it, having detectable viral loads a bad thing? I don't care what your CD4 count is. Our goal is to get you to undetectable, and we need to do it. Connie?
Yeah, go ahead.
From the perspective of the panel, there was a lot of controversy over this recommendation,
right?
as you might imagine.
Yeah.
And people were very uncomfortable just doing it with everybody for all the reasons that we've already talked about. But this was, I think, a compromise position. And looking at the people who are at highest risk for something bad happening and
Trying to figure out how to
trying to
define
figure
that.
out how to articulate that without going too far is really how we got to that point.
Okay, let me, and then the 4 versus 8 week. So all of the data in Latitude and all of the data in Ward 86, which is by far the largest data set, started with every 4. Would anybody start with every 8? No. Just go with the data, right? And then, I should say Ward 86, then if they did well for 3 months, they offered them every 8. So there was a possibility of a switch down the road. Very last case, I promise. It's a complicated one. I'll try to distill it into its simplest form. 50-year-old man, this is a patient of mine I've been following for probably 20 years. CD4 of 1990s with a CD4 of 150, lives 2 to 3 hours from clinic, very far. No past, probably in LA with traffic, it could be even longer. No past medical history except dyslipidemia and a history of non-Hodgkin's lymphoma that was in remission. Labs are stable, Hep B, surface and core antibody positive, HCV negative. Many regimens over the decades, including NNRTIs, non-boosted PIs, first-generation integrase inhibitors, often with poor tolerance, particularly to the boosted PIs and viremia in the 500 to 1,000 range, problems with adherence in the past with boosted PIs. Ultimately, he's had resistance testing sent over the course of his treatment, but lots and lots of periods of time where switches were made because of his distance without resistance testing actually getting done. We know he has TAMS. We know he has 184V. We know he has at least 2 NNRTI mutations, 103 and 101Q. He had the one darunavir mutation, 50V, with multiple secondary, and he had been viremic on raltegravir-based regimens intermittently for some period of time, but never had a successful resistance tests for integrase. It was just the viral loads were always too low. Ultimately, for the last 4 years, he ends up on darunavir ritonavir BID because of his darunavir mutation, dolutegravir BID because of uncertainty about underlying integrase resistance, and TAF-FTC, and he actually has tolerated it well, but he always has undetectable to low-level viremia, and we've just been grateful for 4 years that nothing has happened along the way. And then in 2023, not that many months ago, he presents with acute myelogenous leukemia. And we find out about it when the cancer center calls to discuss the need to modify his antiretrovirals. So we talked about issues of switching. We talked about switching without resistance, talking about switching with nuke resistance. This is somebody who's got resistance to multiple different classes. So obviously, detailed review of his treatment history, resistance data, and then from a drug-drug interaction perspective. That's what the Cancer Center was all about. So just reminding everybody, we have this great Liverpool resource. And when I plugged everything into Liverpool of what their main concerns were from the Cancer Center, it was consistent with what their concerns were. That boosted PIs were going to be a problem for some of the chemotherapy they were planning to give, and that boosted PIs and lenacapavir, when we think about new drugs and new classes, are going to be a problem for some of the key prophylaxis, particularly against molds, that they would use in somebody who's going to get induction therapy for AML and potentially a transplant down the road. So here we have somebody where we don't have a high barrier drug, right? We think we can get activity out of BID darunavir. We're hoping dolutegravir is active. We actually don't know. And it makes us rely on sort of the original data that we used to use to talk about how to manage people with virologic failure, and that is 2 and preferably 3 fully active drugs. And that came out of Benchmark and other studies just like it. This was the registrational trial for raltegravir in highly treatment-experienced patients, showing that if you look at the sort of the genotypic susceptibility score, the people who had only 1 fully active drug, that was raltegravir, less than half got suppressed. But if they had 2 fully active drugs, including raltegravir, or 3, even better. So we know that we have several different options for people with multi-drug resistance. We have second-generation drugs, like boosted darunavir, dolutegravir, and etravirine or doravirine. And then we have these other drugs with novel classes. T20 is always on the list, although rarely used. And then maraviroc for the rare patient who's R5 only, and then the newer drugs. As you can imagine, a drug, ibalizumab, that has to be given every 2 weeks to somebody who lives 3 hours away from clinic is going to be challenging. And then we have fostemsavir, an oral drug, and lenacapavir, already mentioned. There are some drug-drug interactions that may or may not be an obstacle. So my one question on this case, because I know we're a little over time and I want to have time for some of your questions. So oncology says that, we've looked at the drug-drug interactions. We can't use a boosting agent or lenacapavir because of the interactions with this chemo and or prophylaxis. And which of the below is the closest to what you would recommend the patient take? And I'm going to take the liberty of saying that everybody would agree to keep them on dolutegravir BID and TAF-FTC. Unlike the other case that we described, though, here you do it with a little less confidence that this is going to be enough, because you're basically dropping a boosted PI that we think has some activity. So what would you do with dolutegravir BID, TAF-FTC? Either just do that, use BIC TAF-FTC instead of dolutegravir BID, add doravirine, add fostemsavir plus or minus doravirine, ibalizumab plus or minus doravirine, both fostemsavir and ibalizumab plus or minus doravirine, or something else. Go ahead and vote. So this is the switch in the person who has multi-drug resistant virus without a fully active boosted high barrier agent. We're later in the morning and it's a much, much more complicated patient. I can tell you that the ID person at the Cancer Center and I spent weeks torturing ourselves over what to do next. There's tolerability issues, there's logistical issues, there's drug-drug interactions. Okay. Panel? Nice mix. I can assure everybody that there probably is no right answer for this question.
My philosophical approach to this case is that you just can't get it wrong, right? Because if you do, this person's going to be out of options. So that's going to push me to be more conservative and maybe sort of treat a little bit more than maybe would be necessary because of that. I do like the answer that the audience most commonly chose. And I would add the doravirine, not knowing whether or not it's going to be active with all that NNRTI resistance. But again, feel like you can't get it wrong on this one.
Anyone else have anything different? I think that that's sort of the easiest. You know, I think ibalizumab, we were really tempted to use that with fostemsavir, just to hedge our bets, but the logistics made it absolutely impossible. So we actually ended up going with fostemsavir and doravirine. The good news is it's now 6 months, his viral load's undetectable. The bad news is he's not doing well with his AML, yeah. Okay, with that, I thank you all. Thank you, the panel. Thank all of you. And we do have a little bit of time for questions, I think.
So, I'm going to make the executive decision that you go ahead and just do the questions, because
Okay.
why not?
Okay, perfect.
And here are some questions on the pad, and here is another issue.
Okay,
So we're going to cut it down because we went a little over.
yeah.
So that'll be.
I know, thanks. How far out do you think we are for getting insurance companies to cover cabrolpivirine for patients who are not undetectable with poor adherence? Boy. You know, I'll say something that the guidelines, I think, is the first big step and the best opportunity. There's not likely to be, well, maybe I'm wrong, but a registrational trial in the near future that will get an indication. So I think it's more likely that we can convince insurance companies that we're targeting a desperately needed, a population who has a desperate need, and we have guidelines support. Right now, we have IAS-USA guidelines. Hopefully, DHHS will offer some support. Maybe that'll help us for these select people who need it. I don't know, other thoughts?
Well, just as an editorial comment, we have trouble sometimes covering DHHS recommended guidelines with certain insurance companies that still want to use other therapies. I'm not optimistic.
Yeah, not at the cost.
I don't know, are there any other people want to come to the microphones? Does anyone have any questions? I think most of these are these from earlier in the day, the ones on the right, Paul? Yeah, so it's really, so that's the only specific one that I'm hearing. It's a really important question, and access is an issue. The Ward 86 experience makes everyone think that, oh, we should all be able to get this. It's not that easy.
Here's another one that keeps.
Okay, great. Okay, this is a great one. They targeting you, Darcy, on this one. So, have you tried BID bictegravir TAF-FTC for TB co-infection? And I think specifically they're referring if you're using a rifampin. But yeah, Connie, I know that you also can.
My answer was going to be I will defer to Dr. Benson, but there was really exciting data presented recently.
They took your microphone away, Darcy.
Yeah,
Give her the microphone.
because they knew you were the wrong person to answer the question.
They're trying to send you a message.
Connie, do you want to weigh in?
I'll
Yeah,
defer to
This is
Connie,
really
yeah.
important.
Yes, there was a randomized clinical trial presented at CROI that did exactly that, used what you would consider to be standard of care at this point, dolutegravir twice daily plus nucleoside analogs, and in people getting rifampin for treatment of TB. But twice daily bictegravir was equivalent to the standard of care. And that was all done in a resource-constrained setting. So you might argue, do they even have access to bictegravir, TAF-FTC twice daily in those settings, which most of them don't. But they were brave to do that randomized clinical trial. And if you all will recall, the guidelines have recently as 6 weeks ago, said bictegravir should not be used with rifamycin in the treatment of TB. And there's both that randomized clinical trial, and then there are 2 PK studies that show while bictegravir concentrations are dramatically reduced, they are not reduced below a threshold at which you would expect to see 90% of people having suppressed viral loads, more than 90%. And so I think the confluence of all of those data suggests that you actually can use bictegravir safely in people with TB who need a rifamycin.
And these people also received TAF-FTC BID.
Exactly.
And they tolerated it
And they
well.
tolerated that
Yeah.
perfectly well. So I think, yes, you
And
can do
that's,
it.
I mean, that's going to be a big advance, since rifampin is such a big part of what we're doing for both latent TB as well as for active TB.
Although we don't know what that, having the double TAF potentially is doing.
Right.
For bone and.
But, you know, even
This is
so.
a short, it could be short.
Even
course.
so, you know, a full course of TB therapy for drug-susceptible TB is going to be maybe 4 months now.
Yeah.
There's a 4-month regimen, and for preventive therapy, whether you're using Q12 or every 12-week rifapentine isoniazid, that's also been used in a PK study with bictegravir, and the ultra-short course regimen, you're really only talking about weeks to a few months of therapy at that level, so I think it's a big change.
And then we have some data suggesting dolutegravir once a day may be enough as well.
Exactly.
Yeah, so hopefully the data and the guidelines will help
Yeah.
catch up and help us all out
Well,
in
they've
practice.
just been released,
Okay,
so.
good. Okay, great. Again, thank all of you. Thank you so much, panel.